and the term used for spirometry for the measurement of lung volume. Okay, so what we are measuring, the most important lung volume, we said we are measuring volume and we are measuring flow. So what is the volume? Is vital capacity, right? So do you know what is vital capacity? The maximum amount of air that we can breathe in and out. Maximum, okay? So this is important to know. VC is stands for vital capacity. But we're measuring, but here we call it FVC. Why it's FVC?
Forced vital capacity.
Exactly, force. We are measuring it forcefully. I will explain why we are measuring it forcefully. It's important because, for example, if the EVC is 5 liters, right? So if I ask the patient to take a deep breath and blow, 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 even slowly, he will give me 5 liters. Okay? But I will not do that. I will ask him to do it, blow hard and fast. And why you are doing it fast? I'm just asking simple questions so we can understand better.
There was an obstruction?
Yes, because to differentiate between someone who's normal or someone who has obstruction. Because someone who has obstruction can never blow out fast, all the volumes of the air. So we are timing the blowing. Okay. The next part I want to show you is FEV1. Okay, so FEV1 is forced expiratory volume in first second. So when we do it forcefully, the first second we measure how much he can blow. For example, if somebody has a vital capacity of 5 liters, so how much is the FEV1 is expected to be? 4 liters. So imagine in 1 second, we want this patient to blow 4 liters of this 5 liters. And then we are exhaling normally for 6 seconds. So in the remaining 5 seconds, he exhaled the other 1 liter. 5 liters, he blew 4 liters in first second, and then 1 liter is remaining, and the blow, 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 he will blow everything. So how somebody with obstruction can exhale 4 liters in the first second? It's not possible. Yes. So for sure, you will see that he has obstruction. Okay, so how much we can breathe in and out and how fast? That's why we are measuring. So spirometry is like I said, it's an important diagnostic test that it gives us a lot of answers to a lot of questions. For example, is there any pulmonary disease present? We don't know. Once patient blow, we will see is it present or not. Yes, what type? Is it obstructive or restrictive? Yeah. Okay, let's say obstructive. To what degree? Is it mild? Is it moderate? Is it severe? The other question. And then, is there any combined disease? Could be more than one. We don't know. All these questions will be answered by spirometry. And also the other thing, the therapeutic questions. For example, is the therapy indicated? Okay. If yes, for example, reversibility, you will see. Is it reversible? Is it fully reversible? Partially reversible? Non-reversible? Right. This we can answer by just doing the spirometry. And also the effective of the treatment. For example, is this the most effective treatment? You start the medication, and 2 months later you ask them to come back and you do another spirometry, and you see the difference. How much improvement. This also we can do by. So it's a lot of questions to be answered by just a simple blowing test. But I say simple, but it's not that simple. As long as you know how to do it, it's simple. But if you don't know, it's because it's an effort-dependent test. Okay, so we ask the patient to do his maximum effort. So this is not easy, and this maximum effort is done by instructions and coaching. Okay. Instruction, we always ask the patient how to do it. With each maneuver, we explain and also we demonstrate. Because if we don't demonstrate, they don't know, what to do. And so instruction, demonstration, and coaching is important. As the patient is doing the ABC maneuver, we give them some vocal encouragement. For example, we say blow, 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 blow. If you say blow, they will do blow and then they will stop. They will not continue, right? So this is important. Inshallah, we will. This is the graph after the ABC maneuver. Once we do the test, this is what we see. Okay, on the screen. So the red part is the exhalation part, and the blue part is the inhalation. Okay, so the blue part is not that important because it's inhalation. So sometimes it gives us a lot of also information if there is a fixed obstruction. That I will show you when I have a slide for it. But the red part is the exhalation. If you see the top one, the peak expiratory flow, okay, that's important because that will tell us whether the patient did a good effort or not. Okay, so it's like we said, effort-dependent test. The patient, if he has a good effort, you will see that. If that is low, it could be two things. Could be poor effort. We ask the patient to blow harder, or the large airway obstruction. Okay. Because if you do repeated maneuver and we see all of them, we look at all of them, and they are uniformly reduced, then we can suspect large airway obstruction for the peak flow. Okay. But always we suspect poor effort first, because mostly patients they don't do a good job. So the peak effort is important for that large airway obstruction. And then the red line, this one in obstruction, if we see some scooping, then we are suspecting small airway obstruction. Okay. The other numbers, you see the FEF 25, 50, and 75. Those are flows. Okay. Flows, forced expiratory flow. Okay. In 25 seconds, 50 seconds, and 75 seconds, or MVC maneuver. As the patient is blowing, the machine is calculating the flow in different time intervals. Okay. So why? Because volume and flow, the two things is giving us a lot of information rather than one thing, right? Because flows is also reduced in obstruction, correct? Okay, so here, this is a volume time graph. It's very important. With this one, you can tell the relationship between FVC and FEV1. Let's say we have a patient here and we ask him to take a deep breath and blow hard and fast. Okay, this is a normal person, time and volume. Look what happens. See, it didn't go. It should go. Okay, so see in the first second, how much you blew? 4 liters. Okay, this is normal. So easily the patient take a deep breath and blow, and we exhale. He exhale for 6 seconds. The first second we got our FEV1. That's FEV1, and then the rest we can get the FVC. So now we will look at an obstructive patient. Obstructive patient is not blowing like that. They blow differently. So if you want over FVC, and the ratio is has to be more than 70 actually. So this is an obstructive patient. Okay, we ask, look, how do you exhale? You see that?
Yes.
It's linearly. Okay, it's not. You see the top is the normal person, how he blows, and the obstructive patient is blowing like that. And look at the FEV1. Then the first second, how much he blew?
1 liter.
1 liter, very low. And then the ratio FEV1 over FVC of course drops, okay, because the FEV1 is very low. And now it's restrictive patient. So same full volume time graph. You see, restrictive is different. Okay, so in restriction, we know the patient has either the disease inside the lung or outside the lung, right? So mostly FEV1 is reduced. And it's in much the same way as FVC. Okay. So they are both reduced proportionally, and they are close to each other. So whatever is in is out in 1 second. Okay. So we don't have that much to blow because the airway is not obstructed. The problem is not with the flow. The problem is the lung itself, lung expansion. FEV1 is always reduced in both of them. Okay, in obstruction and restriction. But FVC is preserved in obstruction, but the restriction is low. Yeah. Definitely FEV1 and FVC is both reduced in restriction. But they are close to each other. For example, you see 70 and 70 or 60 and 60 to 70, like they're close. Why? Because the problem is with the lung expansion. It could be inside the lung, which is pulmonary fibrosis, pulmonary edema, lesion occupying space, tumors, and could be inside, the asbestosis, sarcoidosis, all those dust disease. Or it could be outside. Outside is what? Which disease?
Obesity.
Obesity is one of them here, unfortunately.
Myasthenia gravis.
Neuromuscular disease, yeah. The lung is fine, but the muscles cannot do the job. Scoliosis. You know, I have seen a lot here for young boys. Mostly they have or pixis cavity, pigeon chest deformities, and also pleural disease. Pleural also is lines on the top of the lung, so that can also restrict lung to the smaller volume. So think of restriction as a small lung. Okay, everything is reduced, but the lung itself could be normal. Okay, so for that we have another test which is DLCO, we call it, diffusion capacity test. With the diffusion capacity, we can see how much oxygen can be transferred from the lung to the blood. We can see the diffusion. Then we can see, we can know whether the patient has intrinsic restriction or extrinsic restriction. Is it the problem is in the lung? If the lung is good, then we have to look at other things. Pulmonary fibrosis patient, they have low DLCO. Okay, now restriction. So restriction, we already talked about it. What causes restriction? Pulmonary fibrosis, asbestosis, sarcoidosis, and also chest form deformities. So the alveoli is good. No, the alveoli could be damaged, but the airways are good. You see, this is a lung collapse, scoliosis, everything is clear. These are the examples of restriction. And yeah, for restriction, we need to have total lung capacity. If the total lung capacity is also low, then we know this patient has restriction. Because why I'm saying that? Because this could be a bad test. Okay, if somebody doesn't do a good job, you just take a small breath and blow, it will look exactly like this one, restriction. Okay. We're talking about obstruction. What happened to the flow? You see the screen, the flow limitation. They have flow limitation. What is flow? Anyone?
So the amount of air that passes during a certain period of time.
Yeah, exactly. It's clear here, liter per second. Yeah, the volume per unit of time. You want to see how much the person can blow
Over a certain period
over
of
a
time.
certain period of the time. Yeah. So the flow is reduced in obstructive patient. You see, that's why we do it forcefully, the test. Okay, we don't do it slowly, because if you do slowly, we will get the ABC. But if you want, we don't know. You know, we do it forcefully, so we can see for in 1 second how much they can blow. You see this scoop?
Yes.
Yeah, this is shows the patient has obstruction. You know, the blue one is the normal, and the orange is obstruction. Okay. Once we see, most of the time when they call me, they say, take a look at this test, and when I look at it, I don't look at even the numbers, but just looking at the flow volume, I say this patient has obstruction. Okay. Sometimes the test could be, looks like normal, could be 80%. The patient reached 80, but that doesn't mean, if you look at the flow volume group, still if it's scoop, it's not normal. Still we give them bronchodilation, and we can see the reversibility. Okay, because 80 is like the lowest normal limit, right?
Yes.
It's not the patient could have 95% normal, you know. But today he is not feeling good, and he comes and he's like 80. We cannot say, hey, it's 80, let him go. It's normal. No. Look at the graph. By looking at the graph, once you recognize it, then definitely you can, you know, suspect some obstruction. And we give him bronchodilator and we see the reversibility. So obstructive lung disease, you all know, is asthma, COPD, emphysema, cystic fibrosis, and it shows, you see the diameters of the airways, it is narrowed, and it says what are the causes of this narrowing of the airways. It's inflammation, tightness of the muscle around the airways, excessive mucus, loss of elasticity. All this can cause the flow limitation and the narrowing of the airways. So we stop that and we give with this spacer. You see?
Yes.
You can do it also in your lab, in your office. You just simply give the patient 2 puffs. Okay. So put it there. I don't give the patient and say take your puffers because I don't trust their technique, right? So I prefer to do it myself. So I put it here, I open this, I shake it, right? So shake, 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 shake. I ask the patient to take a deep breath, out, blow, 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 blow. Then I put it in his mouth, and I say push and take a deep breath. And hold, 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 and out. See, you can do it on your own. Don't give them and say take your breath. Sometimes they come in the morning, they say I took my bukhar already. I don't trust the technique. Still I do spirometry and still I see obstruction. So I give, because you know the way they do it, mostly people are wrong. So then 2 puffs. So again, we have to wait in between for 30 seconds. And then again you shake it, again big breath and out, 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 and push and big breath and hold. Very simple. And then we wait, make the patient to wait for 10 minutes, and then we will repeat this spirometry. And this is what you get. You see, in 10 minutes you can get the good reversibility. Okay, so this is the procedure for bronchodilator response. First, we assess lung function baseline. Second, administer salbutamol in 4 separate doses of 100 microgram through a spacer. Third, reassess lung function in 15 minutes. Results: an increase in FEV1 and or FVC of 12% of baseline, and 200 ml of actual number constitute a positive bronchodilator response. Okay, so here is an example. Here we did a test on a patient, 25 years old male, 182 height. His PFT is abnormal since, as you can see, the pre-FEV1 is 76% only, less than 80%, so abnormal. FVC is 80%, which is normal. So we give bronchodilator, and post bronchodilation, FVC 95, FEV1 89%, which is normal. So 14% improvement in FVC and 18% in FEV1, and more than 200 ml in actual number is present. So the patient has hyperreactive airways, which is positive for bronchodilation. Okay, so interpretation of spirometry. First, we look at the FVC. If FVC is normal, okay. If low, then it could be obstructive or restrictive. Then we look at the contour of the flow volume curve. If it is scooped, it's obstruction. If it is normal slope, it's restriction. Here we can see the 3 graphs. The first one is normal, the middle one is obstruction, scoop, and the third one is restriction, normal slope. Okay, second step. Okay, FVC is low, then we look at the FEV1. If the FEV1 is normal, then the patient could be normal or borderline obstruction or restriction. If FEV1 is low also, then we look at the TLC. If the TLC is high, it will be obstruction. If normal, mixed obstruction restriction. If low, restriction. Okay, step 3. Step 3, we see both FVC and FEV1 is low when we look at the ratio. The ratio is less than 75% obstruction or elderly, and if it is normal and with normal TLC, then it's non-specific. And if ratio is normal or high with low TLC and Assalamu alaikum. My name is Zarina. I would like to do a breathing test for you today, which is called spirometry. So you will be blowing into this machine, and it will measure how well you are blowing out. Okay, this machine. And I will ask you to block your nose. So you are breathing only through your mouth, okay, not through your nose. Okay, so this test, some people, sometimes they feel a little bit dizzy, lightheaded. So I'm going to have you sitting down throughout the test. All right? Did you take your puffers today?
Puffers?
Any bukhar?
No need.
You don't take anything?
No.
Okay, very good. So this is the mouthpiece that I'm going to give you. So what you do, you have to make a tight seal around this with your lips, and make sure don't close the hole with your teeth or your tongues. Okay? So we're gonna start. So I'll put it here. Before starting, I'm gonna ask you some questions.
Okay.
So your name is Abdul Rahim,
Yes.
and your height
162.
162, and your weight is
64.
64. Okay. So gender, height, and weight is important because with this I can get some normal values for you. We call it predictive values. Okay. So once everything is done, now we're gonna start. Okay. So before starting, I wanna explain to you how you do it. So you take a deep, normal breath, 3 times normal breath, and then big breath till your lungs are completely full, and blow out hard and fast. Blow, 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 blow. When everything is finished, then big breath again. Okay? Yeah, it's not for good. So yeah, very good. Up your nose, normal breathing. Normal breathing, good. 3 times at least, normal breathing, good. Normal breathing, good. Now big breath, big, and push. Go, 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 go. Big breath, big, big, big. Okay, excellent. Stop. Okay, good. Just stop. Relax. You can remove. Catch your breath. Okay, so you did a good job, good effort, and you did for 6 seconds you blow. So if you are ready, we'll do one more time.
Okay.
Okay? Please. Normal breathing. Normal breathing. Normal breathing. Now, big breath. Big push. Go, 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 go. Keep pushing, 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 keep pushing. Big breath. Okay, very good. Thank you so much. Once the test is done, then we have to look at some acceptability criteria. First, it has to have a good start. No hesitation. Extrapolated volume should be less than 150 ml or less than 5%. Second, the exhalation time. It has to be 6 seconds or more. For children, 3 seconds or more. And or volume changes of 25 ml or 1 second of plateau. Third, there should be no artifact. For example, here, letter A, it shows hesitation. There should be no hesitation. Good start. B is coughing. Coughing during the 4th second of exhalation can cause our FEV1, affect our FEV1. Letter C, glottis closure that influence our measurement, early termination or cutoff. So the test has to be done with the maximal effort throughout, with no obstruction of the mouthpiece and no leak. And third is the maneuver acceptability between the maneuver. We have to have at least 3 acceptable tests with repeatability. Second, the difference between the 2 largest FEV1, FVC, has to be 150 ml or less. And the third is the difference between the 2 largest FEV1 has to be 150 ml or less. If the criteria of 2 and 3 are not met, then additional trial has to be obtained. No more than 8 maneuvers should be done because it is tiring. So these are the acceptability criteria from ATS, American Thoracic Society.